One of the goals of an optimum capital structure is to minimize the overall cost of capital, which is the WACC, or the weighted average cost of capital. The exhibit here will give you the steps involved in calculating the WACC for your project. Now, this is the hurdle rate to beat to maintain positive returns and profitability. The weighted average cost of capital represents the company's average cost of financing, considering both debt and equity, and each weighted by its proportion in the overall capital structure. Let's look at this. So, WACC, which is the weighted average cost of capital, equals to KD, which is the cost of debt, into the borrowed capital, the amount, quantum of borrowed capital, divided by borrowed plus owned capital, overall capital, plus KE, which is the cost of equity, into the quantum of owned capital divided by overall capital, which is borrowed capital and owned capital, right? So now let us assume a scenario wherein the hospital project you intend to start requires a total capital of $100 million US. And in discussions with your analysts, you have determined that you will put in 40 million as your contributing capital and 60 million you will raise as debt. Okay? So your borrowed capital is 40 million. Your owned capital, your borrowed capital is 60 million and your owned capital is 40 million. Your total borrowed plus owned, which is your overall capital, therefore, is 100 million. Now, the first step is to calculate KD because you know all of the other variables here. How do you calculate KD? KD, or the cost of debt, is equal to the rate of debt multiplied by, in brackets, 1 minus the tax rate. Right? For our purposes, we have taken the rate of debt as 14%, which includes the rate the bank charges and also any fees, commissions, and other expenses that you have incurred while closing this loan facility. Let's say the tax rate is 30%. Therefore, the net cost of debt, KD, is equal to 14% into 1 minus 30%, and that gives you 9.8%. So, your KD is 9.8%. Now let's come to KE, or the cost of equity. How do we calculate the cost of equity? Firstly, most of the times, equity is not taken into consideration, which is a mistake because it is probably, in my mind, the most costliest form of capital. And it is important that we try and include this also in our P&L statements and account for the same. The formula for calculating the cost of equity is as follows. KE equals to risk-free rate, RF, plus beta, and I will explain this to you in a minute, plus beta into market rate minus risk-free rate. Okay? Okay, so what is the risk-free rate? RF, right? So the risk-free rate is what the promoter could have gotten had he or she invested in risk-free government bonds. So let us say you have this 40 million, and if you were to just put it in a AAA certified government bond, which is backed by sovereign bond, that is risk-free pretty much. And let's say that is 8% or 8.83%. So that's your risk-free rate. Beta is the measure of volatility or systemic risk. A measure of 1 indicates that the local markets as compared to global markets are in line. A measure of less than 1 indicates relatively lower volatility, and beta greater than 1 indicates higher volatility as compared to movement in global markets. These can be computed, and they're also available in various standard databases. Okay? And the market rate, or MR, is the expected market rate of return that you desire. And RF, we've already discussed, is the risk-free rate. Okay? So this, and we calculate this. So we now have the risk-free rate. We have, we go and we find out that a AAA sovereign bond is about 8.83%. The country in which we're starting this hospital, we find that the markets have a beta of 1.138. The desired market return is about 16%, and then the risk-free rate is about 8%. Right? And I think the logic here is the investor expects at least to receive for the risk he or she has undertaken at least 2 times the risk-free rate, which is 16. Based on this, when you put all these numbers into this formula, you receive cost of equity as 16.93%, right? Because the risk-free rate is 8.83, beta is 1.13, and the expected market rate is 16%. So you put all of this into the top formula here, and you calculate WACC as 13.52%. 13.52%. Now that is the hurdle rate. So when you as an entrepreneur doctor are starting a hospital and you account for the cost of your equity, that is the hurdle rate you have to beat from your operations so that your return on investment, ROI, is greater than the WACC to deliver both accounting and economic profit. With that, we come to the conclusion of this section on capital structure. And just wanted to remind you with the statement that I started this with. Where you end up in life mostly depends on where you started. And capital structure is when enterprises and hospitals are founded. And therefore, a sound capital structure has a higher chance of increasing the market price of the shares and securities of the hospital, and therefore leads to higher valuations. Just as we end this, I also want to share a small thought on what I think is important, although indirectly connected to capital structure, and that is about actually starting and designing the hospital. And I would say it's a cautionary tale, because what I've seen generally is that hospital facility designs are often done and are proceeded with without much input from the CEOs, the boards, and or, more importantly, the clinicians and medical staff. So typically, one sees that the architects receive a general brief and they create a standardized box. And most of the time, healthcare professionals, doctors, nurses, and the others have to adapt around this design and box that this architect has provided them. There are studies that have examined the impact of clinical involvement in hospital boards on the implementation and success of quality management systems across OECD countries, especially in hospital design. The evidence is compelling about including doctors and medical professionals in the design of the facilities, but generally doctors are at the periphery of these critical decisions, especially relating to the design of the hospital infrastructure. Now, even logically, when you think of the overall life cycle of a hospital over a period of 25, 30 years, the cost of maintenance is probably as close to 85 or 90%, right? Whereas the cost of initial design in the overall scheme of things is probably less than 10%. So doctors obviously must be deeply involved with the design of the facilities and ensure that the functionality and maintenance that is related to the day-to-day functioning of the hospital is not compromised at the altar of some romantic vision of a high-flying architect. And this is also connected to capital structure, although indirectly, because involving clinicians in hospital design is essential for creating functional and efficient healthcare environments in terms of delivery, which has an impact on your ongoing operational costs. Nurses, for instance, can provide valuable insights that can lead to better and more prompter patient care and better staff satisfaction and the overall well-being of the patients under their care. Ignoring the insights of these professionals who operate within these spaces on a daily basis can lead to designs that may be, aesthetically pleasing but functionally flawed. So don't let the tail wag the dog. Get the doctors and the nurses involved actively when you design the hospital. Let's move to the next topic.